Okay, we're going to be talking about patient-specific rods and implants. And this is something that I first started exploring once I developed more of a robotics platform with my practice for many of the reasons that Dr. Albert talked about. I didn't want to be radiated. I thought it was really important that we had data-driven surgery and that we were personalizing the surgery to our patients. I am a consultant for Carlsmed as well as Medtronic and Globus, so that's part of what we're going to be talking about today. So we're going to be talking about what a personalized implant is, the advantages and disadvantages of personalized implants, why it matters for both our practice as surgeons and for our patients, and what are the disadvantages, cost and reimbursement being the main one that I can think of for a disadvantage. So what is a personalized implant and what now? It's a surgical implant specifically made for a patient's anatomical considerations, whether it be the implant's anatomy or the desired deformity correction that you would like to get. Robotic navigation is important, one, because it helps you acquire data and plan exactly the correction that you want for your patients. And we're going to see that we do very well with that, but sometimes not as well as we would like to without the robotic platform. And evolving understanding about optimal alignment leads to the need to improve surgical planning technique. Cost is not just the cost that we have from patients initially when we do the surgery and we look at the cost of the implants. If we have increased cost for revision surgery, patient longevity, time off work, things like this, it does add in both to a hospital cost as well as a societal cost, and that's something that we have to be mindful of. So the rationale for personalized implants, intrabody cages, improved end plate contract reduces the point loading that you get. If it conforms to the patient's end plates, you're not just balancing off one part of it, so theoretically less subsidence. Personalized rods, you are done once your correction looks like the rod, right? Sometimes we've all bent rods and said, oh, that looks good enough, but then the patient stands up and you fuse them in flat back. So it helps have an intraoperative variable where we can look at and make sure we've done the job correctly. Traditional model is surgeon artistry at its finest, and most of us in this room are really, really good at that at this point, but we always didn't start out that way, right? We've all been 1 year into practice. There's that guy in our hospital who maybe does need a little extra help, things like that. So intraoperative contouring as well is physically challenging, right? The surgeon longevity is important. We're developing carpal tunnel syndrome. We're developing, rotator cuff problems. So the less work we can do in terms of physical labor, the better we're going to be in terms of career longevity. So when I first introduced this, there's a couple of other neurosurgeons at my hospital who have now adopted this, and they're very happy that I brought it in, but they're like, no, it's fine. I like what I do. I'm like, that's super cool. The lead time for manufacturing can be 2 to 5 days. That being said, it's not appropriate for emergent cases, and most deformity cases don't happen within 2 to 5 days. They can be more expensive, but there are cost mechanisms built in, either with regard to DRG codes or NTAP, which we're going to talk about. You can still change your plan. It's okay, right? It's an option, not an obligation. And my outcomes are great. That's cool. My outcomes are great too, but that being said, were they always great, or are we just kind of being a little full of ourselves here, right? We can always do better. And humility is where we end up developing our knowledge. So when do we introduce this technology? If you're the first person and it absolutely bombs, your hospital will never let you bring in anything else ever again. So what you want is where some people have already adopted it, you're still cool, you're not the last person to do it before something new comes in, but that's the optimal time from Psych 101 to introduce a new technology, when it's catching credence and it's not yet something that's like, hey, yeah, it's old, why don't we get something better? We've all learned about radiographic parameters. These are important because we've evolved our understanding of what things look like, but we understand that optimally we need to get patients walking within the cone of economy and within specific parameters that will optimize their longevity and function. Achieving this is challenging. So of these complex deformity patients, the PILL goal was only met in 54.2% of cases, and these are really experienced surgeons. We're not doing great. We're misaligning people by 15 degrees in a lot of cases. If you mess up your sagittal alignment, you are going to fail. You're going to break a rod, and that is the most important radiographic predictor of patient outcomes in terms of failure. Coronal malalignment also matters, so you have to get that correct as well. Malalignment impacts outcomes, increases in mechanical complications, and radiographic complications has the most impact on both ODI and SRS scores in this particular study of 726 ASD patients. But we all know that when they break a rod, they're generally not so happy. If they are, leave it alone. Malalignment can also impact degenerative cases. We can see here that not only are we not meeting our objectives in a certain number of cases, but we're actually making people worse in some cases, and that needs to stop. So how can we do better? Pay attention. Actually plan your cases. We all do it, but having the navigation platform gives you an obligation to do that. Standardization and data-driven surgery. So my TLIF is not going to equal to everybody else's TLIF and vice versa, right? So you need to know what you're doing as a surgeon, and when you acquire and analyze your data, you're going to have that information. You can present it to yourself. And predictive analytics matter. Every surgeon and every patient combination is different, but with the digital twin concept and with looking at, different patients that may have looked like yours, you're going to be able to develop a better surgeon treatment plan for your patient. That being said, surgeons' experience still matters. We're better now than we were 10 years ago as people, right? More experience is less complications, and the robotic, the navigation platform, and personalized implants allow us to kind of equalize the playing field a little bit. The enabling data and technologies we've mentioned is very important. If we have the data today, we can do a lot more in terms of data in the future. And personalized spine surgery is, in essence, about the patient, making things better for your patient and planning your surgeries, right? That's important. But the more data that you can accurately and reproducibly add in for your patient, the more you're going to be able to do for your patients and your surgical practice in the future. And quantitative validation is why good medicine matters. So these are just some platforms that I use. UNID basically allows you to, engineer your rod. You have to do it yourself. This is an example of the planning platform that you'll have. You plan in your correction. And again, your TLIF is not going to be equal to everybody else's TLIF, so make sure you're looking at your own data. A Prevo or any sort of custom intrabody implant that you use, if you get the surgical planning, usually what I do with my workflow is I do the intrabody cages first, and then I upload that to my rod construct, and I upload that to my robotic platform. The custom surfaces, as mentioned, do match the end plate anatomy, so decreases point loading, and that's the clinical rationale. So we can see here in this little video that you can really plan exactly what you want to do in terms of your deformity correction. And why does this matter in terms of cost, which is the topic of our conversation? So more than 20% of patients require revision surgery, which an average cost of adverse events of $147,000, 74 days of hospitalization. That's going to increase as the baby boomers age, and we're going to have 76% increase in 2040 compared to 2014 estimates. So if we cannot get this right, we are going to overwhelm our healthcare system and our hospitals. Rod bending templates yield better accuracy, so we can do this better. Stock intrabody implants as well produce unpredictable alignment, and we can do this better with customs. The clinical data, we see a 42% increase in cases within 5 degrees of planned PIL mismatch within an ISGG study, and a 50% decrease in cases where the mismatch was missed by 15 degrees. So planning and execution matters. So this is one of my cases, for example, not really a deformity case, as Eric would say, but, the lady came in, she was in pain. So she had sagittal goal and foraminal goal. First we started out with the patient specifics. We were able to engineer that in all the coronal, axial, and rotational planes. And we came out with a pretty great result at the end of it. She's great, she's walking, and she has improved SRS-22 and PROMIS scores. So what's the prohibitive disadvantage? Cost. So patient-specific implants yield measurable patient benefit and cost savings, but that being said, they can be $3,000 compared to some orthopedic cages. So the value equation, outcomes versus cost. Certainly you don't necessarily need these in every single patient case, but for severe adult deformity, revision cases, long thoracolumbar constructs, 4-to-1 in the T10 to pelvis, they may really matter. They're not necessarily for degenerative cases or one level, or if you're a really experienced deformity surgeon, but certainly in your first, couple years of practice, or once you get used to it, and then the data benefits, they do matter. They're not a substitute for good carpentry and being a good surgeon. Certainly, this is just an adjunct to that, and it will not replace bad work. So make sure that you're always doing your best. So my perspective, you use these in high complex deformity cases or in some degenerative cases based on patient need and value analysis. The literature still needs long-term mechanical failure data, cost-effectiveness analysis, and prospective data. Don't blindly adopt it. Be intentional. And in some but not all cases, the outcomes justify the cost. Precision is powerful, and Justin is irreplaceable. Thank you.